Hello, I'm Mohammed Sarich, Director of Non-Invasive Cardiology and Professor of Medicine at NYU Langone Health. This lecture will be on the diseases of the aorta. These are my disclosures. And let's look at the overall design of this lecture of the disease of the aorta. We'll talk a little bit about aortic anatomy, then we'll talk about aortic coarctation, aortic aneurysms, aortic dissection spectrum, and please note that I am talking here about the aortic dissection spectrum, which include several entities, such as intramural hematoma, true dissections or classic dissection, as well as penetrating ulcer. Then we'll talk a little bit about aortic atheroma, and finally, aortic tumors. Let's start with the aortic anatomy. So aorta and arteries have shared the same etymology. If you never think about it, let me just show a little bit of a Greek etymology for these words. Both the aorta and artery were essentially originally referred to bronchi and a tracheobronchial tree rather than the arteries themselves, something that carries the blood. But eventually they were applied to systemic blood vessels. And let's look at the basics of aortic anatomy. Aorta is clearly the largest artery in the body, and therefore sometimes is referred to as arteria magna or arteria maxima. This is the rendering of the entire aortic tree and also relationship to the esophagus, which is depicted here as a yellow tube in this illustration, will allow us also to show the relationship between the aorta and the esophagus. This is another view, a side view from the aorta, and showing all the appropriate parts of the aorta from its origin at the left ventricle all the way to the iliac bifurcation. At the top is clearly the thoracic aorta, and at the bottom is the abdominal aorta separated by the diaphragm. Thoracic aorta consists of a proximal arch, proximal arch as well as the distal arch. Proximal arch cannot be well visualized by the TE, and we'll see why that is the case. An abdominal aorta cannot be typically visualized by transesophageal echocardiography except for the very proximal portions around the origin of the celiac trunk or the mesenteric, superior mesenteric artery. And now let's look why the proximal aortic arch is obscured by a tracheobronchial tree. Again, this is the rendering of the aorta as well as the yellow colored esophagus. But this time we are looking from the posterior aspect of the patient. See the esophagus, and then if I overlay the tracheobronchial tree, you see that there is the interposition of the tracheobronchial tree between the esophagus and the proximal arch, obscuring imaging of the proximal arch by transesophageal echocardiography. So air-filled tracheobronchial tree interposed between the esophagus and the proximal aorta, obscuring our views on transesophageal echocardiography. Then we can again see the relationship to the heart itself and the swirling of the esophagus around the aorta. In the distal portion of the thoracic aorta and the proximal abdominal aorta, esophagus is the anterior to the aorta. If you go more proximal to the mid-esophageal view, esophagus is to the right of the aorta. And then in the most proximal portion visualized by the transesophageal echocardiography, esophagus is posterior to the aortic arch. And we will see that when we visualize the dissection of the aorta, while these relationships are important. The aortic arch is the location where the three neck vessels take off. From left to right, there are innominate or brachiocephalic artery, then the left common carotid artery, and then left subclavian artery. And just past the left subclavian artery is the aortic isthmus. It is an important part of the aorta because that's the location of ductus arteriosus, as well as the origin of type B dissection should one occur. This is the innominate artery or brachiocephalic artery, left common carotid and left subclavian represent a normal branching pattern. However, you will often encounter the term bovine branching pattern, in which the brachiocephalic and left common carotid artery have a common origin, while the left subclavian still originates on its own. This is a complete misnomer because cows actually don't have that branching pattern. This is the true branching pattern because the cows have very long necks, so they have the entire brachiocephalic trunk with all three vessels originating. So, and that we can say that the cows have a common origin of all neck vessels. The so-called bovine branching pattern actually exists in cats and dogs, and this is a rendering of a cat anatomy, and actually see there is a common origin of brachiocephalic and left common carotid artery in the so-called bovine pattern. But actually, we should probably call this a feline or feline pattern of branching. Now that we looked at the anatomy of the aorta, let's look at a little bit of the aortic coarctation. What's coarctation? So coarctation is a congenital narrowing of the proximal descending aorta. And the narrowing occurs primarily around the ostium of the ductus arteriosus in the region of the ductus, or so-called juxtaductal region. And this is, again, the aortic arch with the isthmus region, but this time the ductal area is represented with the narrowing as the source and the location, typical location of aortic coarctation. The first description of aortic coarctation is credited to the Italian anatomist Morgagni, and he is Giovanni Battista Morgagni, an Italian anatomist from the late 1600s and early 1700s. This is his original publications on the location and causes of the disorders. He published in 1761, and this is in one of his letters or epistolas. He described in Latin, which I'll translate here in English in a second, and the yellowed is the relevant part, in which says, and the aorta was contracted to an amazing narrowness near the heart. So therefore, this is clearly the first description of coarctation of the aorta. And this is the entire paragraph translated into English. And so why does the coarctation occur? We don't know exactly what the embryology of that anomaly, like many other congenital heart disorders, but we know that it's related to the development of the so-called aortic arch, sometimes referred to branchial arch. So branchial means referring to the gills, and that's well developed in fish. So this is the rendering of the aortic arch, somewhat artificial illustration, because these arches, here listed 6 of them, never exist all 6 at the time. Some develop, then regress, then other arise only for some other to regress. So branchia refers to gills, and this is a large fish, and these are the branchial arches in the fish that exist in totality. And that's very important for fish because they have no lungs. That's the way they absorb oxygen from blood. But here is the human embryo at a very early stage, and actually you can see all the branchial arches. In this case, there are 4 of them at the time of the development. And there is a very complex way of modeling and remodeling aortic arches until finally the 4th arch gives aortic arch, and the 6th one gives the ductus arteriosus. And it is this region that narrowing occurs that will then develop into coarctation of the aorta. And this is what's the cause of the coarctation? We don't know the exact mechanism why it occurs. We don't know. We know that the prevalence is relatively rare, 4 per 10,000 births, and that it's associated with several conditions, including bicuspid aortic valve. 25 to 50% of subjects with coarctations have a bicuspid aortic valve. Of course, the opposite is not true because the bicuspid aortic valve is much more common. 1 to 2% of all live births have bicuspid aortic valve, so therefore only 5% of subjects with bicuspid aortic valve will have coarctation. Another association between coarctation and Turner syndrome exists, and about 10% of Turner syndrome subjects will have coarctation. Turner syndrome is the XO karyotypes. So those are short-statured women with webbed neck, broad chest, widely spaced nipples, and amenorrhea. And this is Henry Turner, an American endocrinologist who was the first to describe the Turner syndrome. And this is an illustration from his original publication. And so what are the clinical manifestations of coarctation? It's usually detected by auscultation, and there is a flow across the narrowing segment of the aorta, may lead to a systolic or continuous murmur, best heard in the interscapular area. Also, coarctation is sometimes detected first during evaluation for hypertension, and this hypertension is characterized by elevated blood pressure in upper extremities and a relative hypotension in the lower extremities. And this hypotension is probably related to hypoperfusion of the kidneys and the compensatory activation of a renin-angiotensin-aldosterone system. And again, this hypertension is isolated systolic hypertension of the upper body, typically in milder form, but you can have both systolic and diastolic pressure elevation in the upper body with more severe forms of coarctation. And another clinical manifestation is weak pulses in the lower extremities, and femoral pulses are delayed and diminished compared to the radial pulses. And this pattern is known as the tardus parvus pattern, which is characteristic in general of occluded arteries and the manifestation that occur in post-stenotic region. So tardus and parvus pattern is a post-stenotic observation in occluded arteries. It's another interesting association is between a coarctation and a decreased interpapillary muscles in a short axis view. So this is a short axis view of a patient with a significant coarctation, and actually you can see that the papillary muscles are closer to each other than you usually see. And this is a graphic representation. Left heart, normal left heart is on the left. There is a significant separation between the two papillary muscles, and a coarctation where the two papillary muscles are closer to each other. And let's look at how echocardiographically we evaluate for coarctation. The principal view is clearly suprasternal transthoracic view in a side-by-side color and non-colored image, and there is a clearly coarctation at this level. This is just the ductal level with the flow acceleration as well as the diastolic runoff. That's the location of the coarctation on the suprasternal transthoracic view. And the arrow points to the flow acceleration in systole as well as the diastolic runoff. This is the spectral Doppler continuous wave across the coarctation, and this is a significant coarctation for two reasons. This is a prototypical flow pattern. There is a high systolic gradient, and there is a continuous antegrade diastolic flow. So this is a high systolic gradient. Here it's about 4 meters, indicative of very significant narrowing at the level of coarctation. And then we have a continuous antegrade flow across the stenotic segment. You may recall that the normal flow through the aorta is a pulsatile systolic only with a very brief early diastolic reversal. In contrast with coarctation, when it's significant, there is a continuous antegrade flow in diastole. And what are the flow alternate? There might be a flow alterations in the different levels of coarctation as well as the level of collaterals. So if there is more collaterals, there will be less flow across the coarctation. Also, it depends whether the PDA is patent or not. PDA patency may diminish the flow across the coarctation and therefore abolish the pattern that I just showed. This is pressure tracing in a patient with coarctation on a pullback. On the left-hand side is the post-stenotic flow. On the right-hand side is the pre-stenotic flow. This is proximal to the coarctation and a distal to the coarctation. There is a clearly step-up gradient in systole from, or I should say step down from 140 millimeters of mercury proximal to about 85 post-stenotic pressure. However, if coarctation is significant and if enough time has passed, the patients will develop extensive collaterals around the obstructions. The big arrow points to the coarctation, while the other arrow points to the extensive collaterals, including intercostal arteries, subclavian artery, internal mammary, scapular arteries. Here, the most prominent intercostal artery. And here I'll show you the moving image as I rotate the reconstructed MRI image of a patient with a severe coarctation and extensive collaterals. On a chest X-ray, extensive collaterals can be recognized by notching in the ribs. Rib notching by intercostal arteries is relatively insensitive findings, but if you do see it, it's an indicative of these extensive collaterals, intercostal collaterals that then erode into the ribs, creating these notches. And it's also important to differentiate between coarctation, which is characterized by development of collaterals, and a pseudocoarctation, which is just the folding of the aorta in the same region as the coarctation, but without collateral development, because there is no true obstruction to the level that coarctation demonstrates. And now, what's the impact of coarctation on distal flow? There is a spectral Doppler of the abdominal aorta that I'm showing now, and we will divide it in the tardus and partus, late and weak systolic flow, systolic characterization. This is, remember, that's a post-systolic portion, the post-coarctation portion of the aorta, post-stenotic, and this is a tardus and parvus, or late and weak systolic flow, with the diminished peak velocity. And at the same time, in diastole, there is a continuous antegrade runoff, referred sometimes to as diastolic tail. According to 2018 adult congenital head disease, guidelines, Liz, I will have to stop here. This is just I will have to edit this.
Okay.
I didn't I had already start now.
Okay.
According to 2018 adult congenital heart disease guidelines, the diagnosis of coarctation is established by echocardiography, can be established by invasively through cardiac catheterization, but primarily by CMR or CTA, that is the same, magnetic resonance imaging, and CT angiography. It's also important to measure resting blood pressure in the upper and lower extremities. Also, there are recommendations using ambulatory blood pressure measurement, screening for intracranial aneurysm, and sometimes exercise testing to evaluate for exercise-induced hypertension. With respect to treatment, we treat coarctation when the peak systolic pressure arm to leg difference is more than 20 millimeters, and a mean Doppler transcoarctation gradient of more than 20 millimeters of mercury. And these criteria drop to greater than 10 millimeters of mercury if there is a decreased LV systolic function, aortic regurgitation, or very extensive collaterals. And these are the indication for either surgical or percutaneous treatment of aortic coarctation. Now let's move to another topic about aortic disorders, which is aortic aneurysms. American Society of Echocardiography provides a guidelines that was published in 2015 on multimodality imaging of diseases of the thoracic aorta in adults. And this is a multi-society recommendation, of which American Society of Echo is one of them. This is Steve Goldstein, who chaired these guidelines. These intersocietal guidelines from 2015 show that the etiology of thoracic aortic aneurysms are multiple, and here I will discuss the two most common, which is the Marfan syndrome and bicuspid aortic valve associated aortopathy. Marfan syndrome, this is Antoine Marfan, French pediatrician, who published in 1896 a case of congenital deformation of the forelimbs, more pronounced at the extremity, is characterized by elongation of the bones with some degree of thinning. And interestingly and ironically probably, the original Marfan patient, a 5-year-old girl named Gabrielle, probably had a completely different disorder, congenital contractural arachnodactyly, and not what we now refer as Marfan syndrome. This is the original publication by Marfan in French. And this is the original patient, Gabrielle P., also original drawings, but essentially it's probably she had the congenital contractural arachnodactyly rather than the Marfan syndrome itself. And this is a paper from 1971 in which two authors, Hecht and Beals, reviewed the original publication on Marfan and concluded that what the Marfan described was not Marfan syndrome. But what is syndrome that we now do refer as a Marfan syndrome? It's a connective tissue disorder, it's an autosomal dominant pattern of inheritance, and it's due to an abnormal fibrillin gene. And it has a multi-organ involvement, including aortic aneurysm, mitral valve prolapse, tall, lanky stature with long extremities, ectopia lentis, and pectus excavatum or carinatum. So the diagnosis, there is no one particular test that it's definitively diagnostic for Marfan syndrome, so therefore we rely on a systemic score, and many of them are available online, and there are point values for different findings, and based on the number of scores, if it's a 7 or greater, is a positive score, and the diagnosis of Marfan syndrome can be established. Let me show you a quick case of a Marfan syndrome. 45-year-old man with exertional dyspnea and dysphagia to solids. He was previously diagnosed with spontaneous pneumothorax and ectopia lentis, and these are also in the spectrum of Marfan pathology. Echocardiographically, what we demonstrated that he has clearly a very large aortic root aneurysm. And it's a characteristic for the Marfan syndrome to have dilatation of the very proximal portion of the thoracic aorta, referred to as the root. And because of this massive dilatation of the proximal aorta, there is a retraction of the aortic cusps, resulting in severe aortic regurgitation. In this case, there is a severe aortic regurgitation, and I have also labeled his cusp right, left, and non-coronary cusp. So he did have a tri-leaflet valve, but because of the pulling of the leaflets away from the center of the aortic valve, regurgitant orifice is created, resulting in severe aortic regurgitation. On the suprasternal view in this patient, on the left-hand side without the color, on the right side with the color, you see there are signs of severe aortic regurgitation characterized by holodiastolic reversal. Notice this red retrograde flow that occur in this patient, and it's a sign of severe aortic regurgitation. So what's the transthoracic diagnosis in this patient? He has a Marfan syndrome with large aortic root aneurysm resulting in severe aortic regurgitation. And now if you look at back to the guidelines from 2015 on multimodality imaging of the thoracic aorta in adults, these are the aneurysm types depicted in this document, and the pattern B is characteristic of Marfan syndrome, and you notice that it's really intended to involve the very proximal portion, that is to say the aortic root itself, sinuses of Valsalva, as opposed to the other pattern that might involve more distal portion of the ascending thoracic aorta. And then if you go back again, there is really the emphasis that in Marfan syndrome, there is the aortic root aneurysm resulting in severe aortic regurgitation. Now let's switch gears to bicuspid aortic valve related aortopathy. As you know, bicuspid valve can come in a different fusion patterns between aortic cusp. Right coronary and left coronary cusp fusion is the most common. It involves about 80% of all bicuspid aortic valves, and this is an example of such a pattern where there is a raphe between the right and left coronary cusp. And here now is the moving image on a transesophageal echocardiography. Again, if I freeze the image, there is a raphe between the right and left coronary cusp. Again, the most common form of bicuspid aortic valve. The next common form is the right and left coronary cusp fusion, which is about 20% of all the bicuspids have this pattern. Again, I will show you a transesophageal echocardiogram of a patient with bicuspid aortic valve. Here, there is a raphe between the non and the right coronary cusp, first in a still image, and then I'll show you in a moving image. Again, if I freeze the image, there is a raphe between the non and the right coronary cusp. And the remaining pattern of the non and the left coronary cusp is very rare, maybe 1% of all bicuspids or even less. And this is one such case where there is a very tiny raphe between the non and the left coronary cusp on a transesophageal echocardiogram, first on a still image and now on a moving image. Sometimes there could be a bicuspid valve, but the raphe is almost impossible to see, and we won't be able even to tell the pattern. But in this case, there is a tiny raphe between the non and the left coronary cusp. And now in one medley, I'll show you all three patterns. Right and left, the most common, then right and non-coronary cusp, moving image, and then the still image. And finally, the left and non-coronary cusp fusion, the rarest form of bicuspid valve, first as a moving image, and then as a still image. Now let's see how that the bicuspid aortic valve patterns affect the pattern of aortopathy. So the location of thoracic aortic aneurysm is dependent on the type of bicuspid aortic valve fusion. The pattern of aortopathy is not the same when you have left and right fusion as opposed to non-coronary and the right cusp fusion. Let me just show you normal laminar flow on an MRI image. This is a normal flow through the aorta, through the trileaflet aortic valve, and the flow is a laminar throughout the thoracic aorta. However, in cases of bicuspid aortic valve, the flow is no longer laminar, becomes turbulent, but the point of turbulence depends on the type of the bicuspid valve. Let me show you first an example of the right and left coronary cusp fusion and the pattern of the flow. And now you can actually see that there is a vortex formation, and that vortex is directed toward the outer curvature of the thoracic aorta. So the pathological flow vortex hitting the outer curvature of the aortic valve when we have a right and left coronary fusion. And then this is in contrast to when there is a right and non-coronary cusp fusion, where the vortex is directed toward the inner curvature of the ascending aorta. And now, because of these different flow patterns, there is a different aneurysm anatomy. If you have a right and left coronary cusp fusion, the ascending aortic aneurysm tends to be in the tubular portion of the aorta, while when there is a right and non-coronary fusion, the aneurysm tends to extend into the aortic arch. So, and once we establish the diagnosis of bicuspid aortopathy, we may consider surgical indications. And these are from the New England Journal of Medicine 2014 summary, and actually can see whether we intervene, and when we intervene depends not only on the presence of the bicuspid aortic valve, but also the aneurysm size. And it's probably the most common indication when the aneurysm is a 45 to 49 millimeter, then the in centers with good experience, then when the aortic valve replacement and aneurysm replacement will be done if the aortic valve is damaged. On either end, if there is a 50 to 55 millimeters, it's a definite indication for aortic valve aneurysm repair and aortic valve replacement in cases of significant aortic valve abnormalities. These guidelines are modified whether there is a pregnancy or athletes, in which these guidelines become stricter cutoff values. Now let's switch to the aortic dissection spectrum, and I'll start with a case presentation. 80-year-old man presents with severe headache and non-exertional chest pain in a setting of severe hypertension with the blood pressure of 210 over 90 millimeters of mercury. He was admitted to our institution for hypertensive urgency. However, the chest pain continued even after blood pressure was brought under the control. Then an acute coronary syndrome possibility was entertained, and however, his acute coronary syndrome was ruled out. Then aortic dissection was suspected, and a chest CT was obtained. And this is his chest CT non-contrast portion. So these are the images that are obtained of the thoracic aorta before the intravenous contrast is injected. And these are very important to obtain these non-contrast images. The good news is that he did not have aortic dissection, but there is something very concerning on this non-contrast CT. This is the section of the aorta that I am referring to, which would be the distal aortic arch and a proximal descending thoracic aorta. So what we saw on his non-contrast CT was a crescentic hyperdense lesion involving distal arch and the descending aorta. This is a zoomed up image, and you actually see that there is these hyperdense lesions that are characteristic of intramural hematoma. So intramural hematoma is a part of the dissection spectrum. And this dissection spectrum is also referred as acute aortic syndrome, which includes intramural hematoma, penetrating atherosclerotic ulcer, as well as classic aortic dissections. The aortic dissection was first described on autopsy in 1760 of King George II of England, while intramural hematoma was described much later in 1920 by Krukenberg in Germany on an autopsy. And a penetrating ulcer was described even later in 1986 on aortography and CT at Mayo Clinic. So aortic dissection, as I said, was first described on autopsy in 1760 by King George of England. This is in his fancy clothes. And for us Americans, it's relevant that it was after him that our state of Georgia is named. He is Ernest Krukenberg, German pathologist, who published contributions to the question of dissecting aneurysm, and this is why actually he described intramural hematoma, and he correctly deduced that intramural hematoma and subsequent dissection result from rupture of vasa vasorum in the aortic wall. Back to our patient. 6 weeks later, severe chest pain recurred, and the repeat chest CT was ordered. So this is his chest CT 6 weeks later. There was an increase in the thickness of intramural hematoma with appearance of contrast inside intramural hematoma. Now, his finding is clearly different. This is a CT image in the same region of the distal aortic arch and a proximal descending aorta. And now you see the increase in the size of the intramural hematoma. And now I can show you in this coronal cut section through the distal aortic arch, and you can clearly see increased intramural hematoma. So 1 day later, his chest pain got even worse, so chest CT was repeated. And what do we see now? We actually see conversion of intramural hematoma into aortic dissection, proving indeed that intramural hematoma in some instances is a true precursor of aortic dissection. Again, it's the same region of the distal aortic arch and the proximal descending thoracic aorta, and now we have development of the false lumen in that region. So now intramural hematoma has dissected internally and then eroded into the true lumen, resulting in a classic aortic dissection. Again, there is an intramural hematoma conversion into true classic aortic dissection. And this case is interesting because it really shows a progression over 6 weeks from intramural hematoma to classic aortic dissection. This does not imply that every dissection starts as an intramural hematoma. Some dissections do start as dissections first. So what are the teaching points of this case? That intramural hematoma was first described by Krukenberg of Germany in the 1920s, and intramural hematoma likely results from vasa vasorum rupture in the aortic media, and intramural hematoma is best visualized by crescentic thickening of the aortic valve on CT or the transthoracic or transesophageal echocardiography. And intramural hematoma is a form of acute aortic syndrome and may be a precursor of classic aortic dissection. Again, these are the three elements of the acute aortic syndrome. It was first described as such in 2001 by Villacosta and San Roman of Spain, and now the acute aortic syndrome is commonly used in clinical practice. And this is their original publication as an editorial in Heart Journal in 2001. And also in the textbook of the American Society of Echo, Comprehensive Echocardiography, there is extensive section on acute aortic syndrome that was written by my colleague, Dr. Cronzen, and myself. This is the second edition, and soon the third edition will be published again with the updated chapter on this topic. And now let's talk about true dissection. Classification of dissections are different based on whether we use the Beike classification, and this is the Beike, who is Lebanese-American surgeon, who proposed this classification in the 1960s, his original classification, 1965, And the other classification is from Stanford University in California, done in 1970s, and it tends now that the Stanford classification is more commonly used. And this is from our chapter in the ASE textbook, when we compare the type A, type B dissection of Stanford classification to corresponding the Baker classifications. Type A in Stanford classification corresponds to type 1 and type 2 of the Baker classification, while the type B Stanford classification corresponds to type 3 of the Baker classifications. I'll show you a couple of examples of dissections both on CT and echocardiography. This is a type B aortic dissection, both in the axial cuts on the left and the sagittal cut on the right. And you actually see that the true and the false lumen in the descending thoracic aorta, in the coronal cut, as well in the axial cut. Axial cut is very important because it shows that the type B aortic dissection characteristically starts just distal to the origin of the left subclavian artery. So the arrow points to the origin of the dissection flap, and it's separating false from the true lumen in this patient with type B aortic dissection. This dissection, in particular if they're chronic, can be visualized by the MRI, and the MRI is rarely used in acute aortic dissections. And here we have the abdominal aorta imaging by the MRI, true and false lumen, and we actually see that the right renal artery comes off of a true lumen, the left renal artery is from the false lumen, leading to hypoperfusion of the left kidney. Again, on the left is the axial cut, on the right is coronal cut. Let's look at transthoracic echocardiography. Can we detect dissections on transthoracic echocardiography? Here I'll show you an example of type A aortic dissection seen by transthoracic echocardiography. First, on the right-hand side, I'll show you a still image. This is a parasternal long axis view. The structures are labeled, and the arrows point to the dissection flap in the proximal aortic aorta consistent with the type A dissection. And again, here in the moving image, you can see independently mobile linear echo density undulating in the aortic root consistent with the dissection flap of a type A aortic dissection. Again, arrows point to the dissection flap of a type A aortic dissection on transthoracic echocardiography. What are the complications of type A aortic dissection that we can visualize by transthoracic echocardiography? One of the most important is the recognition of pericardial effusion, because the proximal aorta as well as the proximal pulmonary artery are intrapericardial, and therefore type A dissection can lead to extravasation of blood into the pericardial space. Here on a still image, yellow arrows point to pericardial effusion in somebody with the type A aortic dissection. Dissection flap in this patient could not be well visualized by transthoracic, but its consequence, which is pericardial effusion, it's a circumferential, can be. And recognition of a new pericardial effusion with a severe chest pain should always raise the possibility of type A dissection in appropriate clinical setting. So in this case, hemopericardium is a complication of type A dissection, and this is one of the rare forms of significant pericardial effusion with tamponade that should not be treated with pericardiocentesis, because urgent surgery to repair type A dissection is the most appropriate treatment. Again, this is a zoomed image of a hemopericardium in a patient with a type A aortic dissection. Again, you see it in the apical four-chamber view. That is a hemopericardium in the early stages of its development. What are the other complications of dissections that we can see on transthoracic echocardiography? In this case, it's a type A aortic dissection complicated by aortic regurgitation. can clearly see if development of new acute aortic regurgitation should always raise a possibility of type A dissection unless a patient has endocarditis. Again, you can actually see that there is a dissection flap in the proximal aorta delineated by the two yellow arrows. How about the type B aortic dissection? What do we see there on transthoracic echocardiography? Here's the suprasternal view. The structures are labeled, and then with the moving image, you will clearly see that there is undulating, independently mobile echo density in the descending thoracic aorta, indicative of type B aortic dissection. You can also see the origin of the left subclavian artery and a characteristic starting point of type B dissection just distal to the origin of the left subclavian artery. Let's look at the subxiphoid view in somebody with a type B aortic dissection. Here you can see the true and the false lumen, as well as you will see the communication between the two lumina. And these communication can exist as a solitary communication or can be multiple communication between the two lumina. Sometimes they are really beneficial if significant branches of the aorta come off of false lumen. So then the communications between the true and false lumen allow for perfusion of such organs. As a matter of fact, one of the treatment, or at least temporizing treatment of type B aortic dissection is a percutaneous creation of communication between a true and false lumen using balloons. Again, communication between a true and a false lumen. How about a TE? What do we see on a type A dissection on a TE? Here, again, we will look for an independently mobile, undulating echo density in the proximal aorta, indicative of a false dissection flap separating true from the false lumen. Again, please notice this independently mobile, undulating echo density representing the dissection flap. Again, the arrow points to the dissection flap. It is also extremely important not to confuse this dissection flap, this independently mobile, undulating echo density, with the masquerader of type A dissection, which is the reverberation artifact. And here, this is a typical reverberation artifact from the aortic wall into the cavity of the ascending aorta. It's twice as deep, consistent with the reverberation artifact. And also you see that there is a reverberation. It's a relatively stiff. There is not, it's not independently mobile, and certainly there is no undulating mobility that it's characteristic of type B dissection. And this reverberation artifacts should really always be borne in mind and should not be confused with the type A dissection. A reverberation artifact in the ascending aorta is demarcated by the two yellow arrows. What can happen with the prolapse of a dissection? So when the dissection flap prolapses through the aortic valve into the left ventricle, it can interfere with the function of the aortic valve, leading to aortic regurgitation. You can clearly see here that it's almost as if patient has two aortic valves. It's illusion because the dissection flap ruptured and now it's prolapsing through the aortic valve into the left ventricular outflow tract. And as a result, severe aortic regurgitation may result. And as this is the case in this patient, you can see the to and fro flow through the aortic valve. It is important to emphasize that there are multiple mechanisms, or there may be multiple mechanisms of aortic regurgitation in cases of type A dissection, in which prolapse of the dissection flap through the aortic valve is only one of them. The others could result from the destruction of the aortic valve by the dissection flap itself, could be because of the dilatation of the aortic root separating the leaflets, and in that case is similar to the mechanism of aortic regurgitation with aortic aneurysms that we discussed earlier. Again, you can see the yellow arrow points to the dissection flap consistent with type A dissection. On a spectral Doppler of somebody with a severe aortic regurgitation due to type A dissection, we may see again holodiastolic flow reversal that it's characteristic in any severe aortic regurgitation, whether it's a type A dissection or not. So it's important to look at this holodiastolic reversal as a sign of severe aortic regurgitation. So if you look at in the coronal cut or short axis cuts through the aortic, we can visualize true and false lumen. And here we can demonstrate that the left main coronary artery originates from the true lumen, which is good for the patient because origination from the false lumen might be fatal. Again, on the right-hand side, we have a long axis and the short axis in a single clip. And finally, the dissection leads to aortic regurgitation. Again, long axis, short axis of the aorta, and then again, a long axis with color showing aortic regurgitation. Again, another case, and it's really there is type A dissection, and this time the left main coronary artery originates from the false lumen, which is extremely dangerous condition and may result in hypoperfusion of the large portion of the ventricle and sudden death. And here you can actually see that really the central portion is the true lumen, but there is a very little flow in the false lumen. We can also look to the right coronary artery. Type A dissections tend to start just distal to the origin of the right coronary artery. So therefore, right coronary artery tends to originate from the true cusp. The yellow arrows point to the dissection flap. Again, so this is a moving image. See the right coronary ostium is proximal to the dissection flap. Again, another case, see the right coronary artery, the ostium is proximal to the dissection flap. True lumen is on the top of the image, false on the bottom. How about TE with the type B dissections? Again, this is the origin just distal to the subclavian. This is a tear inside the media, creating the false lumen, and the true lumen is on the top. So again, see the true lumen on the top and a torn media creating intimomedial dissection flap. Again, just as in case previously on a transthoracic echocardiogram that I showed you, there could be a communication between the true and false lumen. In this case, there are two of them in the descending thoracic aorta. And the clip alternates between the short and the long axis. True lumen is on the top, false lumen on the bottom, and there is a communication between the two lumina. And this is a short axis, false and true. This is a true lumen on the right, false on the left. And you see there is a more flow in the true lumen. How can we recognize the true lumen? So true lumen is typically smaller of the two lumina. It expands systole, and it's the lumen that it's lined with atherosclerosis should one be present. In contrast, false lumen has a convex edge, has less flow, and may contain smoke, sludge, or clot. So this is what I mean by the sharp angle edge. You can actually see as the dissection erodes into the media, you can actually that creates this sharp angle toward the true lumen. And then this is true and false lumen. There's dissection flap on a non-contrast, but if you're not sure which is the true, which is the false lumen, you can use the microbubble contrast or ultrasound enhancing agents, and you see the true lumen will fill first and the false next. So microbubble contrast entered the true lumen first. And then going back to orientation between the esophagus and the thoracic aorta, we have to remember in the distal aorta, in the esophagus is anterior to the aorta. In the mid-esophageal view, esophagus is to the right of the aorta, and in the proximal portion, esophagus is posterior to the aortic arch. So therefore, while the aorta is stationary, has the same path, the esophagus swirls around the aorta, and that then gives illusion of a spiral motion of the flap, depending on where we acquired the image. So this patient, as you will see it in a moment on a CT, has a dissection flap completely vertical in a line. But if you look at it on a TE, there is a apparent movement of dissection flap from the vertical to horizontal position between the two images on the left. And that there is no actually movement of the dissection flap, it's just natural because of the esophagus moves around the aorta. And here clearly on a CT you see that there is the dissection flap is stationary, and the illusion of the movement on the TE of the dissection flap is just simply reflects the swirling path of the esophagus around the aorta. So let's now look at the dissection evolution. What happens to the false lumen? I'll show you here in a type B dissection. Originally, there is a smoke, then there is a sludge, and eventually clot formation in the false lumen. And you can observe 1, 2, or all 3 phenomena in a patient on a single exam. And less flow tends to have in a more distal portion of the aorta, where there is a sludge and clot formation, and the more proximal can have a small or have smoke or even no smoke if there is a still significant flow in that portion of the aorta. So again, this is smoke in the false lumen, then this is sludge in the false lumen, and then there is both the sludge and a clot inside the false lumen. What can we see on a 3D? Does the 3D echocardiography helps? It helps a bit. We can again show the false and true lumen, but is not as 3D. I don't find it as useful as another structure such as the mitral valve, for instance, or left atrial appendage. But again, here you can see that sharp edge that the false lumen creates toward the true lumen. And just as I showed you with the type A dissection, certain anatomic or technical variation should not be mistaken for dissection. For type A dissection, we discussed the reverberation artifact, but for type B dissection, that can something that can be mistaken for type B dissection is a dilated azygos vein. It has illusion that there is a true and false lumen, which actually is not the case. On the top is the descending aorta, and the bottom is the dilated azygos vein. And the dilated azygos vein is not very unusual because a certain percentage of patients, there is no intrahepatic inferior vena cava, and then the entire blood from the lower portion of the body is then directed through the azygos vein into the superior vena cava, resulting in a significant dilatation of the azygos vein. And you will not be fooled that this might be a dissection if you make a short axis view in the same patient, and you clearly see that these are 2 different vessels with a systolic flow in the descending aorta and a continuous venous flow in the dilated azygos vein. How about intramural hematoma on echocardiography? Here, this is on a CT just for reference. Again, crescentic thickening without the lumen in it. And this would be intramural hematoma on TE. Again, crescentic thickening without internal lumen. It's just a thickening characteristic intramural hematoma, which may be a precursor for dissection in ensuing weeks. And the final part of the aortic syndrome, acute aortic syndrome, is penetrating atherosclerotic ulcer. This is erosion of atherosclerotic plaque in the media and tends to occur in people with severe atherosclerosis. Clearly here it's a very complex atheroma with the multiple mobile components, and there is an ulcer in between them. And then if you look at the short axis view, you see the mobile components, but then underneath the mobile components, there is a penetrated ulcer, so the entire plaque has eroded, and now blood enters the media, creating the penetrating ulcer, and sometimes it can erode even past the adventitia, creating a pseudoaneurysm. And this was the case in this patient. You actually see that this is a contrast CT, and you see that in the proximal descending aorta penetrating ulcer resulted in extravasation into the periaortic space and pseudoaneurysm, both on 2D CT on the left and 3D CT on the right. And essentially this pseudoaneurysm is a focal rupture of the aorta. And what are the guidelines of the penetrating ulcer? In the ASE guidelines for 2015, these are beautiful illustrations of a penetrating ulcer in an unfortunate patient who died and underwent autopsy. Now let's switch gears toward another pathology of the aorta, and that's aortic atheroma. Atheroma is an important source of cardiac source of embolism. And cardiac sources of embolism differ in their embolic potential. High-risk potential and moderate risk potential. High-risk potentials are thrombi, vegetations, tumors, and aortic atheroma. So therefore, aortic atheroma is one of the 4 high-risk embolic potential cardiac sources of emboli, as opposed to moderate risk, such as smoke and sludge, variety of valvular disorders, and as well as abnormalities of the atrial septum. And I'll show you a brief case presentation. 91-year-old man, hypertension, diabetes mellitus, hypercholesterolemia. He presented with the sudden onset of left leg pain and weakness. Angiogram of that leg revealed complete occlusion of the left femoral artery, and a surgical specimen revealed the thrombus. Now let's look at his TE. This is his aortic arch showing severe sessile plaque. It's thicker than 4 millimeters, partly calcified. And then in a different portion of the aorta, you see a large mobile component over the ulcerated plaque that is essentially a thrombus, and part of that embolized into his left leg, creating acute ischemic limb necessitating urgent surgery. And this is the 3D of that patient. You see this is aortic arch seen from the back of the patient. There are large atherosclerotic plaque with a large ulcer in between them. And now I can show you in one image both the 2D. This is severe sessile plaque, severe mobile plaque, and severe ulcerated plaque on 3D. And we have discussed this extensively in our guidelines on the use of echocardiography in the evaluation of cardiac sources of emboli, which I happened to chair. And another pathology of the aorta are the aortic tumors, and I'll show you an example of aortic sarcoma. This is a 56-year-old previously healthy woman. She presented with the new-onset headache and progressive right-sided weakness. She was evaluated by neurologists and neurosurgeons. She was found to have a 4-centimeter left frontoparietal gadolinium-enhancing lesion with surrounding edema and mass effect. A presumptive diagnosis of meningioma was established, and she was scheduled to undergo brain surgery. And this is her brain MRI with the large mass in both sagittal cut on the left and the axial cut on the right. So she was treated with intravenous dexamethasone and underwent bilateral frontal craniotomy for tumor resection. To a surprise to neurologists and neurosurgeons, this was not a meningioma. This was unfortunately malignant high-grade sarcoma. And the transthoracic echocardiogram was ordered in preparation for chemotherapy. I'll show you the suprasternal view of this patient. You see the aortic arch and a part of the descending thoracic aorta, and it's very difficult to see details of the aortic anatomy, whether there is a mass inside the arch or not. However, if you look at the spectral Doppler profile through this aorta, it's a very unusual. There is a systolic high velocity flow, and also there is a continuous antegrade diastolic runoff, which is pretty unusual for a 56-year-old previously healthy woman. So this pattern of high systolic gradient and continuous antegrade diastolic flow is suggestive of coarctation, but this would be a novel diagnosis in this patient in her 56 years of age. And the attending physician who read this study, he noted there is a prominent Doppler flow suggestive coarctation. However, he said, given the clinical setting, this is likely pseudo-coarctation due to either tumor or a thrombus. And he was referred the patient chest CT MR. And he actually proven to be right. These are chest CT on the left-hand side in the coronal cut at the level of the aortic arch, so that we see the origin of large vessels, and you see that the tumor filling the proximal origins of cranial vessels, as well as the mass in the aorta itself. Again, this would be the moving image. You see that there is extensive involvement of the aortic arch, as well as the proximal portion of great neck vessels. And again, here, if you pay attention, this is on the short axis. Again, extensive involvement by the tumor. This is sarcoma in the aorta and extended into the great vessels. Here, these are the MRI still images. The dark color and the black is a tumor in the aortic arch extended into the neck vessels. And this is a TE of this patient. And actually you can see that is a large mass, intraluminal mass. It's very unusual to see this. And this is aortic sarcoma. This is 3D image of a highly mobile, large mass in the lumen of the aortic arch. This is a combination of images by 2D and 3D in a publication of this case. So she underwent surgical resection of the aortic vas. Intraoperative, there was extensive invasion of the aortic arch in all 3 aortic arch branches, and palliative resection of the mass was performed, and also showed histopathology of that mass showed pleomorphic high-grade intimal sarcoma similar to that seen from the brain. So the brain lesion was the metastasis from the aorta. And this is her histology, high-grade sarcoma. It's really a very malignant tumor. So an epilogue, so she was transferred to palliative care and soon died. And we published this case a few years ago in Texas Heart. So here's the reference if you would like to have more information. I hope you enjoy it, and thank you very much.